Okay, everyone, thanks so much for joining. If I can just ask everyone in the audience to make sure that your camera and microphone are off. You can hear a little bit of noise at the moment. So I'm delighted today to open this Neuropsychiatry Academic Meeting to welcome Dr. Merit Millman, who's a postdoctoral research associate at the IOP, and she'll be presenting her slides on the interesting topic of online structured dance movement therapy, which reduces bodily detachment in depersonalization-derealization disorder. And this session is online and in person, and will follow the usual format. So we'll have a presentation from Merit, and then we'll have a question and answer session afterwards. As usual, please either put your messages in the chat, so the conversation function, and I can come to those at the end of the talk, and we can ask Merit those, or stick your hands up and we'll give you the opportunity to ask the question via the camera at the end. But until then, please keep your cameras off. And we also may have some questions from the audience here in person too. So keep your cameras and microphones off until then. Don't take control of the slides, however possible that is. And if anyone is hearing impaired and needs captions, just click on the 3 dots in the toolbar and press turn on live captions. So I'm hoping you can all see the slides online, and without any further ado, take it away, Merit.
Thank you. Okay, so let me just make sure that hopefully everyone can see those now online. But yeah, thanks for the intro, Matt. As he said, my name is Merit. I'm a postdoctoral research associate here in psychological medicine at the IOPPN. But today I'm going to be talking about some of the core research from my PhD that I did at Goldsmiths and finished this past November, looking at dance movement therapy for depersonalization-derealization disorder. So just to give a little bit of context, I have a mixed background in both psychology and neuroscience and dance and choreography. So the goal has always been to kind of try and bridge these together. So it feels important to start off with what actually is depersonalization-derealization disorder. So it's defined as experiences of unreality, detachment, or being an outside observer with respect to one's thoughts, feelings, sensations, body, or actions. It's classified as a dissociative disorder in the DSM-5 alongside dissociative identity disorder and dissociative amnesia. And it has a prevalence of around 1% in the general population, but it's still widely unknown and underdiagnosed. And I had pretty much the same stories from every individual that I spoke to in terms of the time it took to actually get a diagnosis. And this was on average 7 to 10 years. So it's really an area that needs a lot more research. And onset is most commonly in adolescence or early adulthood, and it can be brought on by a whole host of things, including trauma, substance use, stress, fatigue. There are a range of possible precipitating factors for the disorder. And it can evoke questions regarding the sense of self, reality, and phenomenology of experience. And as it says in the name, this kind of splits into 2 main types of symptoms. So there's the depersonalization side, which is that disconnection from the self. So that might materialize as emotional numbing or anomalous bodily experiences or feelings of disembodiment. And then on the other side, you have the derealization aspect, which is that disconnection from reality. So that can be an alienation from surroundings or foggy, distorted, or dreamlike experiences. And transient or kind of short-lived experiences of both depersonalization and derealization are relatively common in the general population. I think it's around 23%. And these can occur in response to fatigue, trauma, substance use. I think they've kind of increased as well in the wake of COVID-19 with things like Zoom fatigue and all of that. So these transient experiences are common, but it's when they shift from being transient into something chronic that you may end up with a diagnosis of this disorder. As I've already kind of alluded to, there are a diverse array of symptoms that may be present in this disorder. So things like distorted experience of time, visual perceptual distortions, an unreal or absent sense of self, feeling as if one is in a dream, feelings of detachment, and sensory impairments. And what's particularly interesting is that these individuals have intact reality testing, so they're aware of what is happening and that these things might not be necessarily normal. So it's very different from something like psychosis, for example, but there's a striking change in the nature of their personal experience. And symptoms of DDD may also be observed in other psychiatric disorders, including PTSD, panic disorder, depression, and schizophrenia. And altogether, DDD is characterized by heterogeneity, comprising diverse symptomatology that overlaps with both anxiety and other dissociative disorders. In terms of the evidence-based treatment for depersonalization-derealization disorder, there isn't a ton, unfortunately. Cognitive behavioral therapy has been the one that's shown success as kind of a primary treatment of choice up until this point. However, it's been suggested that the improvement that was seen in the depersonalization or derealization symptoms may actually be heavily tied to reductions in depression and anxiety instead of, directly affecting those symptoms themselves. So obviously that's still very beneficial, but there needs to kind of be more research looking at how we can directly impact those particular symptoms. And general issues include case studies, and if they're not case studies, the sample sizes are quite small. And there's a lack of efficacy of treatments or inconsistent evidence across them. So a core feature of depersonalization, as I've mentioned, is this experience of physiological numbing or sense of detachment between one's sense of self and their body. And it's possible that these types of experiences may partly reflect altered or deficient interoceptive processing. So I'll take you through a bit what interoception actually is. I'm sure there's some familiarity with this. But overall, it's a sense of awareness and understanding of the internal state of one's own body. And interoceptive states are kind of the building blocks that might contribute to the self, where the self is grounded in the body. And interoception encompasses dissociable dimensions, including accuracy, awareness, and sensibility. So there's kind of different aspects of interoception under that wider umbrella term. And compromises to the function of interoception have already been found in a range of psychiatric and psychosomatic disorders, including hints at this in depersonalization-derealization disorder, where there has been underactivity in brain regions that are associated with interoception, so including the insula, and some studies looking at accuracy as well and showing differences there. Another concept that's linked to interoception is mindfulness. So this is paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. And mindfulness-based therapeutic interventions might help to focus attention on interoceptive stimuli. And mindfulness is something that has previously been shown to be reduced in DDD as well. So it's possible that this is linked to those suggested deficits in interoceptive awareness. And mindfulness training has been recommended as a potential therapeutic approach for DDD. So altogether, disorders with an interoceptive or embodied component like depersonalization-derealization disorder may actually be very good targets for treatment that involve the physical body. And my suggestion is that one form of physical activity that could be particularly useful in potentially altering interoceptive awareness or enhancing kind of body awareness and mindfulness is dance movement therapy. I'm just going to hide this because I realize it's been on the screen the whole time. So dance movement therapy is the psychotherapeutic use of movement to promote the emotional, social, cognitive, and physical integration of the individual for the purpose of improving health and well-being. And it's based on the idea that bodily and psychological changes reciprocally influence one another. So a core feature of dance movement therapy is the observation of one's own body and attending to physiological signals and physical boundaries. And DMT can have, and has been shown to have, a positive impact on health-related psychological outcomes and well-being in conditions including Parkinson's disease, dementia, and fibromyalgia, for example. But the literature regarding dance movement therapy for the treatment of clinically diagnosed mental health disorders is rather sparse in comparison. So something that I did in my PhD as well was conduct a systematic review on dance movement therapy for mental health. And the goal of this was to highlight the potential clinical efficacy of DMT as a treatment tool across specific clinical disorders. So in this review, we identified 15 studies that used either group dance movement therapy or body psychotherapy in depression, schizophrenia, autism, and somatoform disorder. And the findings overall suggest that DMT and BPT can have a positive impact on mental health, particularly in mood disorders. However, there are many outstanding issues with this literature in general. So It's kind of unclear if these results would be observed with other forms of exercise and what the specific effects of these interventions actually are. So there's not a lot of discussion about that. And in the review, we suggested that embodied cognition and interoception might be core mechanisms that underlie these types of therapies and are potentially the reason why they might work. And we've also suggested that future research should aim towards developing manualized disorder and symptom-specific treatments, which is something that I tried to do in the work that I'll discuss with you today. So hopefully you're already somewhat convinced, but why movement for DDD? I really like this quote. I think it sums things up really nicely. So if detachment is conceptualized as a separation from a sense of self or the environment, then treatment should focus on grounding and orientation to the self and the here and now. So mental health disorders that involve or are rooted in the body may be more directly and effectively accessed by generating bodily experiences rather than discussing their absence in something like talk therapy, for example. So dance movement may be a powerful intervention in this case. And the tasks that I've developed in my research use the physical experience of moving the body as a means of symptom reduction. So I'll take you through the online study that was part of my PhD. This was originally an in-person study that then got pivoted online when COVID hit. So yeah, we ran an online study using dance movement as a tool to develop a greater awareness of one's body in people with DDD, as well as a control group of clinically healthy individuals. And one real benefit, alongside other things that were obviously problematic with having it online, a real benefit is that you can recruit and include people from all over the world. So we did have 40 participants total that were living in England, but we also had people from a range of different countries, which is a really nice aspect of this. And we developed 2 dance tasks that didn't require any prior dance experience and could be performed without an instructor present. And both tasks were performed alone and at home, which is kind of unlike traditional dance movement therapy that's typically performed in group settings. So that helps to have some better control for potential social influences that may be at play in group dance movement therapy. And we also wanted to use 2 very different dance tasks instead of one dance task and then a no intervention control group to allow us to better examine why symptom reduction may occur. So is it due to the addition of aerobic exercise, or is it due to a specific explicit focus on the body? So these are things we were trying to tease apart. So our kind of core research questions then were, first of all, does DDD come with alterations in interoception and mindfulness? Secondly, can a controlled dance movement intervention reduce depersonalization-derealization symptoms? If so, is it better to work with explicit bodily sensations or implicitly enhance the salience of bodily sensations through dance-based exercise? And that you'll see in the 2 different tasks that I'll tell you about next. And then, is heightened interoceptive awareness or mindfulness actually associated with decreased levels of dissociation? So the 2 tasks, the first one is called the body awareness task, and this was rooted in principles of body scanning and somatic practices. So with this one, participants are really explicitly asked to direct attention towards the body. So it's very guided, and there's a real focus throughout the entire task on bodily sensations. So they start off with a warm-up that involves some stretching and kind of asking them to tune into the present moment, notice how their body's feeling, things like that. And then in the actual task, participants are asked to use a stress ball or a tennis ball or a comparable object, and they're guided through rolling that object along the surfaces of their body. So the arms, the neck, the head, torso, and legs. And all the while doing that, they're asked to really focus on what the sensations are that they're experiencing as they're rolling this object on the body. Eventually, that object is removed and they're asked to kind of reimagine what those sensations were and then eventually respond to them. So they're able to kind of move in the way that feels right for them in that moment. And then the complete opposite side of the spectrum is the dance exercise task, which is focused on aerobic physical dance movement. And if you think of a Zumba class, that gives you a good idea for what this kind of entailed. So the goal of this one was to implicitly boost the salience of bodily signals. So it was a simple choreographed phrase. Again, there was a warm up and then the task itself that followed along with the rhythm of a piece of music. And what's important to note is that at no point throughout this task were participants asked to focus on their body. So with this one, you know, ideally you'd have kind of an increased heart rate or breathing rate. Maybe you would sweat a little bit, so it would boost those signals, but you were never asked to focus on the body, whereas with the other one, it's very explicit. So those are the two different tasks that I developed. And in terms of our kind of key dependent variables in this study, we were obviously looking at interoception. So with that, we were using the multidimensional assessment of interoceptive awareness, or the MAIA, as I'll now call it, which is a self-report questionnaire looking at trait-level interoceptive awareness in different dimensions. So that includes things like trusting or not distracting or self-regulation. And what's important to note as well is that most of the interoception research that's been done in DDD thus far has only looked at accuracy. So I don't think, as far as I'm aware, anyone has looked at this type of interoception in depersonalization before, up until now. Then with mindfulness, we use the 5-facet mindfulness questionnaire, or the FFMQ, to measure trait mindfulness. Again, this also splits into different subscales, so things like describing or acting with awareness. And then for the depersonalization-derealization symptoms, we use the Cambridge Depersonalization Scale. Again, looking at overall scores, but then also looking at one particular subscale, which is the anomalous bodily experiences subscale, to see if these tasks can actually tap into that specifically and help reduce those symptoms. In terms of the design, it's quite big, but I will guide you through it now. So we had all participants complete some baseline measures, so things like depression, anxiety, obsessive compulsive symptoms. We also included a vividness of visual imagery questionnaire, because that's something that has said to be altered in depersonalization as well. We included a measure of dance sophistication or dance experience, and also a suggestibility measure. And that is reported in a whole other study that is already published online if you're interested in suggestibility and depersonalization. So we ended with 31 individuals in the DDD group and 29 healthy controls. They were then randomly assigned to either the dance exercise task first or the body awareness task first. So half the group got one, half got the other. From there, before we had our first session, they were sent a questionnaire pack with the CDS, the MAIA, and the FFMQ. So they were asked to complete that just ahead of us having our session online. And then in that first online video session, which was all one-to-one, I would take the participant through the task. So we'd go through the warm-up together, we'd go through the task together, whichever one they were assigned to, and make sure that it was all clear and that the participant was comfortable with doing this task at home. From there, we went into, oh no. There we go. Sorry about that. The first 6-day at-home period. So across those 6 days, participants were asked to practice the task once a day. They were provided with audio instructions as well. So there was a recording of the warm-up and a recording of the task that they were asked to follow along with, so that we knew that participants were doing the same thing at home. So once a day, whenever it fit into their schedule. And along with completing that, there was a kind of brief daily diary sheet that included state symptom ratings, pre and post task, as well as ratings of how difficult they found the task to perform and also how they felt overall afterwards. So after that 6 days, they then came back, completed those same questionnaires again. So that was kind of time 2. And then we had another video session as kind of like a check-in to see how the week had been, what the comments were in general, feedback, if they had any questions, that kind of thing. And then from there, we had the second 6-day at-home period. So that's identical to the first. So they were asked to continue practicing the task and completing the diary sheet across the second 6 days. And then that ended with day 15. So the end of the 2 weeks, they were sent another set of questionnaires, which was again the CDS, MAIA, and FFMQ. So we have those at kind of time 1, time 2, time 3, or pre, mid, post the 2 weeks. From there, there was a 4 to 6 week washout period. So participants were asked to stop performing the tasks that they had been assigned to and just continue with their daily life as normal. And then everyone came back and did the opposite. So if you were originally doing the dance exercise task, you would now be completing body awareness and vice versa. So that's the overall design. Hopefully that was all clear. So our key hypotheses here were that dissociative symptoms will be elevated and interoceptive awareness and mindfulness will be reduced at baseline in depersonalization compared to healthy controls. Dissociative symptoms will decrease and interoceptive awareness and mindfulness will increase after the interventions in the DDD group. If an explicit attention to bodily sensations is helpful, then we would expect that the body awareness task would decrease dissociative symptoms, improve interoceptive awareness and mindfulness. Whereas if an implicit awareness of the body via increasing the salience of bodily signals is helpful, then we would expect the dance exercise task to do that. So these are some results at baseline. I want to mention as well, the groups were comparable in terms of age and sex. And they differed in the ways that you'd expect them to with regards to variables like depression, anxiety, obsessive compulsive symptoms. So those were all elevated in the DDD group. The DDD group also exhibited less previous dance experience, but they were matched in terms of general levels of physical activity. And then if you look here at the top, we've got the Cambridge Depersonalization Scale scores. So those are the kind of overall scores. And clearly the DDD group is scoring very high. To give you an idea, the clinical cutoff on the CDS is normally recommended to be 70. And this group on average was scoring 152 at baseline. So they were exhibiting a lot of symptoms. And obviously controls scoring well below that cutoff. And we see the same with that anomalous bodily experience subscale as well. In terms of interoceptive awareness overall, so overall scores on the Maya, we see that controls do exhibit higher levels of interoceptive awareness, so as predicted. And they also exhibit specific elevations on certain subscales of the Maya as well, including attention regulation, self-regulation, and trusting the body. And then with the mindfulness questionnaire, we see the same. So again, controls exhibiting higher levels of overall mindfulness at baseline, as well as a couple of specific elevations in terms of subscales. So non-judging, describing, and acting with awareness. So there are differences there between our two groups at baseline. In terms of how symptoms and interoception and mindfulness changed over time, so these are different ANOVAs here. So this first one, we're looking at two weeks after performing both tasks, so the dance exercise task and the body awareness task, symptom severity in the DDD group was reduced significantly, and those are large effect sizes as well. So this is obviously really exciting to see, and this is what we were hoping for. I believe that with the body awareness task, the symptoms went down, I think, by 17 points on the CDS, and dance exercise, it was 20. So those are pretty significant reductions there. Obviously, nothing's happening in controls because there was a floor effect because their symptoms were already so low. But yeah, so this was exciting to see that happening with overall symptoms. And we had the same pattern when looking at that anomalous bodily experiences subscale. So we see the same thing where from week one, time 1 to time 2 to time 3, after performing both tasks again, those anomalous bodily experiences are also reduced. So these tasks appear to, help reduce those types of symptoms in depersonalization, which again is very exciting and what we would be hoping for. In terms of interoceptive awareness, or those kind of overall scores on the Maya, what we see here is that in the DDD group, there actually wasn't really anything happening. So from pre to mid to post, those scores didn't significantly change. But in controls, actually both tasks helped to improve their levels of interoceptive awareness. So that makes sense in terms of, relationships between dance and interoception in general, and is kind of a nice finding anyway, just to show that, in healthy populations, these types of things can also work. And then with mindfulness, so overall levels of mindfulness, what we have here was a significant group by treatment by time interaction. So mindfulness scores improved more in the DDD group after performing the dance exercise task, so the more aerobic one, whereas in controls, it was the opposite. So mindfulness scores improved more after the body awareness task, which is the one that's probably a bit more intuitive in terms of improving mindfulness, given the focus on the body. But it was with the dance exercise task that improved more in the DDD group. So obviously that's all great and nice to see. We can see that both tasks, help to reduce symptoms overall, as well as anomalous bodily experiences, but we don't really know what the differences are between the tasks. So these are some of the repeated measures correlations that help to at least a little bit tease apart why the two tasks might work and what their differences are. So with this, what you can see here are, we've got the dance exercise task on the left, body awareness on the right. The top two figures are looking at the relationship between overall symptoms and mindfulness. And then the bottom two are looking at overall symptoms and interoceptive awareness. So what you can see is that in all cases, regardless of the task, there is an association there. So lower depersonalization symptoms are linked to elevated mindfulness and interoceptive awareness, or vice versa. And so each color here as well is a different individual. So yeah, there appears to be an association between symptoms, interoception, and mindfulness. Then if we look at the anomalous bodily experience subscale of the CDS more specifically, and the relationship between that and overall interoceptive awareness, we can see that there is a significant relationship between those two variables with the dance exercise task, but not with the body awareness task. So in this case, increased levels of interoceptive awareness are tied to decreased anomalous bodily experiences, but only with performance of the dance exercise task. So that shows, okay, there's a little bit of a difference there between the two. And then if you look at just one example of a subscale from the mindfulness questionnaire, which is the describing subscale. So that includes things like, putting beliefs or opinions into words and describing bodily sensations. You can see that the relationship is only significant with the body awareness task. So again, that's the one where they're explicitly asked to focus on their body. So it kind of would make sense that these two things might be related, but only in the context of that task. And a final example is with the trusting subscale of the Maya. So things like feeling at home in the body, or trusting it, feeling that it's a safe place. The relationship between that and symptom scores is only significant with the dance exercise task. So that one that is more aerobic. So these hopefully help to tease apart a bit why the two tasks might both work. Okay, now I'll talk you through the daily diary very briefly. So these are mean daily state depersonalization scores that are measured pre and post task. So we've got the mean scores for day 1 pre-task, and then mean scores for day 1 through 12 post-task. So pre are the triangles on the figure, post are the circles. Again, the DE task is in purple and body awareness is in green. And what you can see in the DDD group, which is that top figure, across time, daily state depersonalization scores decrease with both tasks in that group again. And what you can see is it's kind of especially prominent, at least in that figure, with the dance exercise task, where it kind of reliably decreases each day, and appears that it would possibly keep going if they had performed it for longer as well. So that's really nice to see. And what's interesting too is that in controls, if you look at the green, so the body awareness task, you can see that actually performing that one elevated some dissociative symptoms. So in these individuals that weren't really experiencing any, that task actually brought on some of those types of things, which is an interesting thing to think about as well. In terms of task difficulty, the DDD group did rate the body awareness task as more difficult to perform compared to the dance exercise task, but there was no significant difference in ratings of how participants actually felt after performing either of them. Obviously, the stats and numbers are great to talk about, but I think it's equally important to discuss what people's experiences actually were. So these were some comments that came up from the DDD group across the study period. So one individual said that I feel that both tasks in different ways encourage me to think about my physical body, which is obviously great to hear. Some specific examples with the dance exercise task. So again, that's the more aerobic one. Noticing, less feelings of numbness, or feeling more attuned to the body, being able to recognize things more, feeling better just because they've done something that has gotten their heart rate going, or noticing that they feel a bit more grounded and more in control or less unreal. So those are very positive and exciting comments to hear. And same goes with the body awareness task. So for one person, they said it's been good to remind myself to slow down, bring my awareness back and away from the quick thoughts and emotions, helped to ground me and feel every part of my body. And someone else said, this was after the first week, maybe 2 out of the 6 times that they felt really good about it and they could feel the connection coming back, and it's exciting and it does help. So obviously, you know, these are all kind of promising comments, and it's really important to note as well, like the high levels of individual difference here. So for some people, there was a real preference for one over the other. Some people really enjoyed the warm up of one task, but then the actual task of another. So these are things that need to be taken into consideration when thinking about using these types of therapies for individuals with DDD, that there is high variability across individuals. So to sum all of that up, I know that it's a lot. Lower levels of overall interoceptive awareness and mindfulness were seen in the DDD group compared to healthy controls at baseline. Dance or movement interventions do reduce dissociative symptoms in DDD, either by enhancing the saliency of bodily signals or by developing the individual's ability to verbalize and focus on their bodily sensations. Lower levels of symptoms are associated with task-specific elevations in body awareness. And dance may be an effective complementary treatment approach to reducing bodily detachment in depersonalization-derealization disorder. I think it's also important to note that the tasks that are used in the study are accessible. They don't require prior dance experience, and they can be easily integrated into existing treatment plans and the daily life of individuals with depersonalization. So that kind of sums up the online bit. In the interest of time, I'm just going to talk about a couple little things from the in-person study. But essentially with this is one that got derailed and then finished off towards the end of my PhD. We used the same 2 dance movement tasks, and the general study design was also identical, except it was obviously happening in person. So for this, we ended with 18 individuals with depersonalization and 14 healthy controls. And this one included both self-report and behavioral measures. So the self-report measures were all exactly the same as the online study, so I won't talk about those, but I will take you through what behavioral measures we included. So we included a heartbeat detection task. So this is a measure of interoceptive accuracy and confidence in those judgments. We also included an endpoint position matching task, which is a measure of proprioceptive accuracy, or how accurate one is with regards to their body positioning in space. And then we also included a temporal and color bisection task. So the temporal bisection task was used as a measure of interval timing, and the color bisection task was included as a control for that. So these were all the additional measures that we had in person. And we also asked participants to wear Empatica E4 wrist sensors to monitor both heart rate and acceleration throughout task completion at home. So the point of these was to try and gauge the physiological differences between the 2 dance tasks. So I'm just going to talk about the baseline results across interoceptive dimensions here, and then also a little bit on the physiological differences, because everything else is too much to get through for today. So the nice thing about having this in person is that we have the MAIA, which is that self-report trait level measure of interoception, but then we also have the heartbeat tracking task that looks at accuracy and confidence. So if you're not familiar with it, essentially in that task, participants are asked to try and notice and count how many heartbeats they're feeling over pre-specified periods of time. They'll then report that number, and that number is looked at in comparison to the actual number of heartbeats. So they get this accuracy score, so how accurate they were in correctly detecting the number of heartbeats that were actually happening. And with each accuracy judgment, they're also asked to make a judgment of confidence. So how confident are they in their judgment of how many heartbeats they felt? So with this, what you can see, the same as the online study, where there is a difference in overall levels of trait interoceptive awareness at baseline. So controls are exhibiting higher levels of that, but there are no differences in accuracy or confidence on the heartbeat tracking task. So this just kind of shows just how important it is to reliably examine interoception across dimensions, because they do measure distinct things. And it's kind of nice to be able to look at if there are associations or not, and yeah, what links together. And if you look at some of the correlations here between these variables, again, just at baseline, what we can see is that there were no significant results with accuracy and awareness, or awareness and confidence in either group. But between accuracy and confidence, so both those judgments on the heartbeat tracking task, There's a significant relationship in controls, wherein if they were more accurate, they were also more confident, and vice versa. So those things were correlated, but we don't see that same relationship in the DDD group. So there's potentially some sort of disconnect there. So even though they're not performing any differently to controls, in fact, their scores are actually slightly better, their confidence, or those judgments, don't necessarily line up with their actual scores. So this is something to look into further. And symptom reductions that we saw in the DDD group, so like the online study, the in-person study, we also had the same sort of reductions in symptoms, both overall and on the anomalous bodily experiences subscale, which is great. So that replicated. Those symptom reductions were not linked to changes in interoceptive accuracy or confidence with either task. So it didn't really appear to be anything going on there. So objective measures of task performance, as I said, we use the Empatica E4 wrist sensor worn at home only when they were doing the task. So they weren't asked to wear this all the time, just for when they were performing the task at home. This was used to monitor heart rate and acceleration. Unfortunately, we had large amounts of missing data due to both technical problems with the sensors themselves and also people forgetting to wear them. It happens. So essentially, with this analysis, it was kind of a pilot analysis of this type of data in the context of this study. So we selected an interval for analysis where there was no missing data present, which happened to be from minutes 4 to minutes 9 in the task, so that 5-minute window. And for both tasks, that interval includes the end of the warm-up and the first few minutes of the task itself. So that's a 5-minute window we're going to talk about on day 1 of task performance. And since we were interested in general levels of activity and physical exercise, these initial analyses were collapsed across both groups. So what you can see here in terms of heart rate, so just to orient you to this, each thin line is an individual, the thicker dotted lines are the average. The dance exercise task is in purple again, and body awareness is in green. So what you can see is that at least on day 1, the average heart rate was significantly higher with the dance exercise task. So that's exactly what you would expect. Obviously, there's clear individual differences here as well, but the DE task does look to produce a higher average heart rate compared to body awareness. So this is just one way of helping to clarify the physiological differences between the task and say, yes, they do different things in the body. And then we also have acceleration. So on the left, you have the individual acceleration profile. So each color is a different person. The top is body awareness task, bottom is dance exercise. And then on the right, you have those average profiles. So again, dance exercise, purple, body awareness task, green. So looking at this overall measure of movement across the tasks, you can see again, across this 5-minute period, average movement levels were higher with the dance exercise task compared to body awareness. So again, that's what you would expect. And it just sort of solidifies the fact that, yes, there are physiological differences between the two, and they are doing different things in terms of how they engage with the body. So to sum everything up, I realize I've gone a little bit fast and we have a lot of time left, but overall, reduced mindfulness and interoceptive awareness are present in depersonalization-derealization disorder compared to healthy controls. And correlations suggest a role for these abilities in relation to DDD symptoms. A reintegration with the body through the use of dance or movement encourages symptom reduction, and more specifically, dance exercise may encourage a sense of comfort or trust within the body, increasing bodily sensations and helping to ground the individual in the present, whereas body awareness may promote a specific type of paying attention to the body and an ability to verbalize bodily sensations. So as well, both tasks differently engage with the body, as we saw with those physiological differences. It's really important to take into consideration individual symptom profiles and subtypes within DDD. So for example, at intake, along with measuring scores on the CDS, you might also want to administer the FFMQ and the MAIA. And then you can look at those subscales and see, are there particular kind of prominent deficits there? And then are we able to kind of tailor treatments based off of those? So obviously these two tasks do different things, so they might be more or less beneficial for an individual depending on where the kind of prominent alterations lie. I personally think the use of dance and movement is an exciting kind of new avenue for therapies in this population. Again, as I said, these types of tasks could be easily tailored to address specific components of mindfulness and interoceptive awareness. And I think it's an important resource for both this population and also other symptom adjacent disorders. So here's a ton of references that I'm happy to send if you want to get in touch. And that's everything. So thanks to my PhD supervisors, Dr. Guido Orgs, Dr. Devin Terhune, and Dr. Elaine Hunter. There's my email and Twitter and our lab Twitter if you want to get in touch. Thanks. Yeah. Where should I go? Yeah, okay.
Thanks so much to Mary for an amazing presentation. Really engaging. I'm just gonna sure. Okay, fantastic. So we've got a couple of questions in the chat, a couple of hands up, and possibly some questions in the room. I guess this has got me thinking about, you know, whether we could do a similar thing with football, which is the time when I feel, you know, most embodied, but perhaps dance is a bit more easy to do. I guess I'm going to take chairperson's privilege and ask the first question, if that's
Sure.
okay.
Yeah.
One of the things I guess I've been learning about sort of interventions as part of my work in clinical trials has been about the kind of interplay of kind of prior expectations, or kind of you know, priming patients to get something out of a therapy or an intervention that perhaps, you know, and the kind of interplay of that with the outcome. I wondered whether or not, you know, you were able to measure kind of the patient's expectations about the interventions, whether or not there was a sense that they held on to the idea that this could, you know, help improve my relationship with my body, or did they kind of go in blind with a sort of hypothesis neutral sort of expectation? They didn't really sort of know what was being measured, if that makes sense.
Yeah, that isn't something that we measured or looked at, but would definitely be very valuable. I think, yeah, it's an issue that's come up before because of the fact that we use two different tasks and we don't have like a no intervention group. We can't really look into that. And it is possible that symptoms do improve because they are working with somebody that cares and they're doing something that, they think could help. So that is entirely possible. In an ideal world, we would have had a no intervention control group as well, but it's an important thing to think about in terms of like measuring what those expectations are, and we didn't do that. So thank you for the suggestion.
That's right. Well, you did well enough to recruit so many people in the midst of the pandemic, though. So
yeah.
Obviously hard on yourself. Do we have any questions from the audience? I don't know whether you want to come up to.
Yeah.
I'm not sure. So the online people
can see or hear. We can swap around.
Firstly, thank you for a fantastic presentation, amazing body of work, really super impressive. Got about 100 questions, but limit us to a couple of minor ones. First one was really just thinking about an observation on the dance sophistication tool that you mentioned. Just interested in that as someone with lived experience of dance dysmotility syndrome, which Bernard for another time. Another sort of acronym related observation about DMT, and obviously with Matt's work, you know, we've got the other use of DMT these days, which is obviously the psychedelic. Yes, so, but the connection to my question, which is really about, you know, thinking about sort of cultural rituals and induction of dissociation, which, you know, through, you know, cultural dance sort of often, you know, psychedelic induced sort of states that obviously you can induce stuff through movement and that all that sort of emotion connection, which we know across so many different things, they're entwined, and, you know, from simple rocking during prayer to, you know, full dancing rituals where you're help to induce your dissociation, I guess. But the question is really about how, you know, it can be seen to be something you used to reduce, but also you can almost capture symptoms by inducing them and going past them, and almost, you know, and again, the same way that you might do, you know, pharmacologically with DMT, sort of blowing your priors up essentially, but you can also do the same with a more natural, you know, in that sense, sort of movement, emotion related things that capture the symptoms and then renormalize rather than being stuck as it were.
Yeah, for sure. I mean, I think that also ties to, even though they're very small, those like slight elevations that we saw in the control group when they're performing the body awareness task. So it's possible there's something in there that actually might, depending on the person, bring on some of those types of symptoms. So I agree, that'll be a very interesting thing to look at. There's possibly another question in the audience. Okay.
I'm going to take one hand up and then I'll go back to the room.
Yeah.
So Tony David, you have your hand up. I don't know whether you want to stick on your camera and microphone. That'd be great.
Yeah, Merit, thanks for that. Really great to hear that work, which I remember you coming to talk to me about it 3 or 4 years ago, and me thinking it'd be great, but it would be something to pull that off. But you've done it really brilliantly well. I think basically the results are really nice. And of course, why wouldn't you want to combine a sort of dance exercise and a bodily awareness in a treatment program, given the heterogeneity of the disorder? But if I may, I'd just comment on the design a little bit, or at least the way you presented it, because I think the data's there anyway. But I mean, in a trial, you don't really compare healthy controls with patients. That doesn't make any sense. I mean, it is interesting to see what happens to healthy people in terms of their awareness, etc. But really, you want to compare the patients going, and the comparison is the two interventions. It's not the two groups. It's it's a between. It's a group contrast, not a within group contrast. So I would have thought that would be a better way of presenting it, and then you could see in more detail where the two interventions differ in patients, one group of patients against another randomized, and whether the order effects are important, etc., etc., and then set aside the effects on healthy volunteers.
Yeah, no, agreed. It's a great point. Thank you.
Well, look forward to seeing it in press anyway.
Thanks.
Thanks, Tony. Do we have another question from the in-person audience? Are you okay to? Or we can paraphrase the question if you like. It's a problem with the microphone question. I'll get out you again.
Okay. Just so they can hear.
Okay. I'm just curious because I was very happy that you only not look into the UK, but there were other countries as well. And as an Argentinian, we have tried tango and we do it in different things with similar things. And when I try to think about doing something with tango here, because it's a closed embrace and so on, it's kind of culturally difficult. So I was wondering if any of them will choose one type of, more vivid, type of exercise, with the other one is more passive. Have you got, I know they're very small numbers, but has anyone made a comment that actually there is more culturally appropriate, or they will be more keen on adapting to one or the other? So I'm curious about that.
I don't remember there being commentary on it, but I agree that would be something to look into, and I kind of wish that I had at this point now. But yeah.
Okay. That's the only
Sorry to not have the data for it.
Great. So I think there are a couple of questions in the chat, but we'll go to you, Tom, just because you've had your hand up for a while. That's okay.
Hi, thank you for a really wonderful talk. I was really impressed by the sort of way you sort of really focused on the kind of possible different active ingredients here. It showed a kind of, I guess, kind of sophistication of approach that I sort of had never really occurred to me, and it definitely, I found myself thinking throughout the whole talk, God, there's so many sort of possible active ingredients that one can kind of harness or focus on. I mean, in the one sense, you've got dancing like there's nobody watching, and then you've got, on the other sense, you've got a kind of dance that brings you, fully inside yourself, and it's fantastic that you try to sort of, to some extent, dissociate them, for want of a better word. One of the things I was just thinking about, the sort of focusing of attention, particularly bodily focused attention, is, if I'm correct, there's a sort of received wisdom, particularly in the mindfulness literature, that with some people, particularly people that have trauma or physical trauma, or physically based trauma, that is, that there can be some difficulties, and it could be potentially triggering to have that kind of focus. And it seems to me that dance kind of offers something extra, so that it does kind of incorporate that possibility to kind of focus externally, or to kind of not have this kind of relentlessly internal focus. And I wondered if you could say something about what you think the role of trauma, or how adaptations to people that have that kind of trauma might look like.
Yeah, I think in that case, probably something more like the dance exercise task would be better. So there was some commentary from a few individuals who found, obviously the body awareness task was rated as more difficult. So in general, people found that sort of explicit attention to the body was more difficult to try and do. And yeah, harder than the dance exercise task. So I think that depending on the case, something that kind of brings you still into your body, but without that focus. So like something more aerobic would be more beneficial in the case of individuals who have experienced a lot of trauma. And we didn't measure, precipitating factors for the disorder. So that would be something interesting to look at in relation to, how the tasks worked and what people's response to them were. So I think that would be, an important thing to do as well in the future. But that would be my inclination in terms of like what might be a better option. So not like really super self-focused, but integrating with the body from a more external perspective, I guess, if that answers your question.
Yeah, it does. Thank you very much.
Thanks, Tom. So there's there's a few questions in the chat actually about, some about methodology, some about sort of interpretations. What's on the quicker one first? What type of dance task did you use, solo and group? Because I think you explained that it was sort of solo dancing.
Yeah, all individual. Yeah.
And for how long each day were they doing the solo dancing?
So the warm up in the case of both tasks was around 5 minutes, and then the task itself was about 15. So around 20 minutes total, not very long at all.
Fantastic. So we've got a question here, a slightly long question from Tassia, which is, please feel free to turn on your camera if you'd like to ask us face to face, otherwise I'm happy to read out. Tassia says, thanks Merit, great presentation. If dance movement therapy was adopted into usual care for people with DDD, do you anticipate that over time they would need to be introduced and to practice different dance sequences? I wonder if their symptom improvement may plateau if they're doing the same kinds of sequences over a long time period as part of their usual care. And do you think the diversity of sequences or routines over time may result in continued or maintained improvements as patients move their bodies in different ways?
Yeah, I completely agree that I think after a certain number of days or weeks, switching it up would be a good idea. That was also, there were some comments on that in terms of, you get to the end of the 2 weeks and it's like, okay, I think I'm ready for something else now. Obviously with the daily diary, we saw that those symptoms were still improving, the daily state ones, but I do think that I'm sure there is a plateau point where it would be helpful to, switch up and kind of have, I guess different protocols that you could put in place. I don't know the second part of the question now, but hopefully that.
Essentially, we're raising questions.
Yeah. Cool.
Thanks. Great. So we've got a question from Earl in the room, but I think because he's at the back of the room, I'll be nice to him and read out what he's written. So again, thanks for the great talk. You've mentioned that patients' attention to interoception is important for DDD. Did you also measure attention in this research, e.g. attentional control?
We didn't, but we did measure, which is something I didn't talk about today because there was essentially nothing going on, bodily vigilance. So, how, I guess that's kind of how much attention is paid to certain types of symptoms in the body. So like headaches or dizziness or stomach upset, things like that. So we did measure that, which is something that, tends to be elevated in like health anxiety, for example. We didn't find any difference between the groups at baseline and nothing changed across the task period as well. So we kind of maybe tapped into attention in that way, but we didn't have any other sort of explicit measurement of it in this case.
Do you want to go any more questions from the, Irene, are you happy to go on, Irene?
Sorry.
Hi. No, I just wanted to ask a specification, like on the scales you used, obviously it's encouraging to see like a reduction in symptomatology, but would that be considered like a clinically meaningful sort of significant reduction, or what was the feeling?
Yeah, it's a good question because it is significant, but obviously if your symptoms are starting at 150 or whatever it was, and they're going down by 20 points, it's still a lot. Like they're not anywhere near what the kind of cutoff would be. So it's making a difference. It's not taking away the disorder or those experiences, but it's just kind of like small improvements to maybe hopefully get to a point where, you might get below that cutoff. But yeah, so meaningful, significant, not necessarily, I don't know, in terms of clinically meaningful, I'm not 100% sure what my answer to that would be, but
That's fine.
yeah.
Thank you.
Thanks.
I think another question for me, if that's okay.
Yeah.
So perhaps not fair because it's not sort of directly related to your work, but at the beginning of the presentation, you talked about your systematic review, which is about dance movement therapy and other disorders or other psychiatric disorders. I'm just wondering if there's, you have a sort of sense of a summary about how what that sort of evidence is, and whether or not there's going to be differences in the way that this type of therapy will be done for example, something like autism or schizophrenia, or if you have any sort of inclinations or thoughts about what might be different about the way it's approached in those disorders.
I think that disorder specific or symptom specific interventions are really important. There's definitely not like a one size fits all, and I think that's been sort of the case in DMT for a while, or it's all it's quite open. And I'm definitely interested in a bit more like manualization and looking at, what would be the key things within each disorder to try and tap into. So I think something like autism would be different. You might be more inclined to do that in a group setting and have things like mirroring, where you're asked to copy the movements of the instructor or something like that. Whereas something else might be much more internally focused and something else might be much more aerobic. So I think, it's important to look at what the symptoms are and really try and tap into that when developing a manual, for example. Hopefully that answers that.
Perfect. Thank you. I guess we're just drawing to sort of towards the end of the talk now. More question from Tim. Yeah, absolutely. Yeah, please.
Very quickly, just to build on the comments about treatment effects and something. Did you look at the effects of chronicity of symptoms, how long people had symptoms in terms of who responded most or didn't? Just because you could argue that doing this earlier on in the symptom generation rather than when it's become quite entrenched might be where it's more efficacious. But just wondering if you looked at that, and if not, and if so, is there effect of that within the data you've got, or perhaps something to look at when you do a huge trial?
Something to look at. We didn't look at that relationship, but I do know. I'm trying to remember the exact range now. There were definitely individuals who I think have reported symptoms for like 11 years. I think maybe the shortest was about a year. So there was variability in there. I think most people were experiencing them quite chronically for a while. But no, we didn't look at that possible relationship. So another good point that I'll need to come back to. Thank you.
All right. Okay. So I can't see any more questions in the chat, so I'll just give one more opportunity for anyone to turn their camera on if they want any final questions, but we are sort of at 2 minutes to now, so it's probably a reasonable time to finish unless any more quick questions.
Very quick.
Yeah, very quick.
Would patients be like keen to continue after the study?
Yeah,
what did they say?
Some of them were. I think particularly with the more aerobic one. So, if they had felt that was particularly impactful, they were quite keen to just keep doing it. And they had the recordings and, they could sort of develop their own way of going about it as well. So yeah, that was a comment from some people, which was nice to hear too.
Fantastic. So thanks so much again, Merit.
No
I thought it was a really great talk. I feel quite energized by it. I'm not sure if that's because we've been dancing around each other to get to the microphone or not, but no, wonderful talk. So we don't have any more neuropsychiatry academic meetings for the rest of this summer, so we have a bit of a summer break. So look out for the programme for the new term when that arrives. Thank you all for listening.
Matt, just going to say, people, please put yourself forward if you want to present something or suggest people that you'd like to hear from. We obviously reach out not just locally, but nationally and internationally. So please do suggest speakers you'd like to hear from, and put yourself forward if you want to have data or topic you'd like to present. Thanks.
Wonderful. Thank you.